इंसान के लिए बीमार होना सबसे ज्यादा महंगा है। अगर परिवार में कोई बीमारी आ गई तो वो परिवार कर्जदार बन जाता है, और एक तरफ बीमारी में और दूसरी तरफ कर्ज में उसकी पूरी जिंदगी तबाह हो जाती है।
ये देश जब आगे जाएगा जब जो लोग उन सड़कों को बनाते हैं, उन पुलों को बनाते हैं, उन रेलगाड़ियों को चलाते हैं, उनके पेट में जब तक खाना नहीं होगा, जब तक उनके पास दवाई नहीं होगी, तब तक ये देश आगे नहीं चलेगा।
60 million Indians are crushed into poverty each year because of unaffordable healthcare expenditure.
We have this problem of tackling at the same time the communicable diseases as well as the non-communicable diseases, but having to do this at income levels which are fairly low.
दुर्भाग्य है कि हमारे यहाँ मेडिकल कॉलेज भी बहुत कम है, और जो है वो भी डोनेशन सिस्टम से चलने वाली साउथ में एक बहुत बड़ा नेटवर्क है।
Public financing of health must go up. If not straight away to 3%, at least to 2.5% of our GDP.
The private sector is a very important partner in the health sector, and if we want them to join the government in delivering health services to the people, then it should be very important to make sure that regulation of the health sector is undertaken effectively.
पहली बार हमने हेल्थ सेक्टर में पब्लिक प्राइवेट पार्टनरशिप का मॉडल विकसित किया। हमने डॉक्टरों को जोड़ा और हमने कहा गरीब परिवार की कोई भी प्रेग्नेंट वुमेन अगर आपके यहां आती है तो पेमेंट हम देंगे, उसको ट्रीटमेंट मिलनी चाहिए।
Private hospitals cater to wealthy people, but it is very important that we give health care to everybody and the weakest people in this country.
Hello and welcome to Change India, an agenda for the next Prime Minister. Today in the fifth show of our series, we have 10 policy initiatives that will enable the next Prime Minister to transform India's sick health sector. These have been culled from recommendations made by a group of experts, and you can get all the details from our website, thinkindia.in.com. Joining us in the studio are four of these distinguished contributors. We have Mrs. Anjali Nayyar, Senior Vice President of Global Health Strategies, an international consulting firm. We have Dr. Ashwini Kumar Setya. He's a senior consultant in gastroenterology with Max Healthcare. Dr. Partha Shah, President of the Center for Civil Society, one of India's top think tanks. And joining us on a satellite link from Hyderabad is Dr. Rama V Baru, Professor at the Center of Social Medicine and Community Health at the Jawaharlal Nehru University. And with them is Dhiraj Nayyar, CEO of Network 18's Think India Foundation, who has anchored this project. We also have an audience in the studio, among whom are some people who have actively pitched in to the debate on Twitter and on our website. I would urge all of you to contribute to future editions on Twitter and our website, and we would be delighted to invite you to participate in the upcoming shows. Do note that we will present our suggestions on health and 13 other policy areas to the next Prime Minister who takes office in June. The first one is what you heard in the video as well, double government expenditure on health from 2% of GDP to 4% in 5 years. That's the first one. And the second one is linked to that you must incentivize the better performing states. Therefore, the transfer of resources to the states must be linked to their achievement and fulfillment of targets. Let me begin with Dr. Rama V Baru here. How achievable are these, and if yes, how should the Prime Minister go about achieving them?
I think the first point that you made is absolutely essential, because during the last round of discussions, even in the Planning Commission, they were constantly saying that we don't have enough resources to invest in health. So I hope that the next Prime Minister will have health on the top of the agenda and will in fact double as per the recommendations that the first point makes.
Right.
As far as the second point is concerned, my only concern is that the poor performing states are also the financially weaker states. So while we will say that, increase performance to get better transfer of funds, we would also have to look at how we balance this and how we support states that are not financially in a position to really invest in health services. Having said that, I think the status of NRHM would also have to be reviewed, and I hope that the next ministry, whichever political party comes to power, would not sort of dismantle the efforts of the NRHM program,
right,
and would actually beef it up.
Right.
Yeah.
So therefore, one of the recommendations that we made, taking into account the financial weakness of states, is that the transfer should be linked to delta. It should not be linked to the absolute level, but the rate of change at which states are able to enforce some of these recommendations. So let me come to Mrs. Nayyar here. We've also suggested that there should be a lot of public-private participation. Government should also be financing healthcare, not just giving land and some other resources. Is that something which will augment the resources?
Yes, absolutely, it will. And just to add to what Dr. Baru was saying, that the 12th plan actually talks about increasing these resources right up to 2.5%, and I feel that that's not going to be enough. We have to look at much more. And of course, we've seen there are several examples where public-private partnerships have benefited, and there are real case histories or models or good experiences that we can go by. But the private sector cannot be seen as a default. That if something doesn't work, give it to the private sector. We really have to see how we can strengthen public sector, and at the same time have those services that the public sector cannot for some reason perform, or to lessen the burden on the public sector, we can outsource to the private sector.
Yes, and I think later on in the recommendations, we are specifically going to look at that. But I also want to pick up very quickly one more point, and this is the National Health Insurance Scheme. How can that be made much stronger than we've been able to do?
A lot really depends on how that insurance scheme is implemented in several states. There is some concern. I think medical insurance is really beneficial. All of us in the middle class, upper middle class, we all have medical insurance. And I think the poor class, it's really going to be beneficial. The finance minister did talk about, increasing the RSPY to below poverty line people as well. Couple of concerns that have come up is that will that lead into really corrupting the system to the extent that people will be given unnecessary medical procedures, not knowing, so that they can avail of the money. One will have to put in a system where it's absolutely above board, it has to be monitored, and you will have to do pilots and see how it goes up.
So let me get a practicing doctor in here. Dr. Setya, both these points, especially the public-private partnership and the national health insurance.
See, I would take your second point first. As well as the national health insurance is concerned, right now there is about 16,000 crores spent to cover about 243 million people on the Rashtriya Swasthya Bima Yojana. But we are also having insurance in the private sector and insurance generally. Unfortunately, I dare say that the four stakeholders, that is the insurance companies, the service providers, that is the hospital, the doctors and the patients, at times all are dishonest. Which is the point which I'm taking from her.
So what's the sort of safeguard against that?
The safeguard against
effective
this is,
safeguard.
Yeah, see, the penetrance of insurance is less than 5% even in metros. So if there's more penetrance, that means the volumes would rise, and the claim of the insurance companies that they are bleeding because their claim ratio is more than 100% would then be laid to rest. And if you pay more in terms of premium, then the restrictions which they impose would then go away.
Dr. Shah.
I think it's hard to argue against spending more money on healthcare. My fear here is that if you focus only on the expenditure part of it and not actually how that money is going to be spent.
I mean, but that's a given. But that's a given. The question is, how do you do it?
My fear is it's not really given. Unfortunately, it's not, because if you look at what happened in education, the same thing was argued there. If you increase to 4 to 5 to 6%, somehow we get better education in the system. But that's not happening. And therefore, I think the idea of PPP is very important idea. Building on that further, whether we like it or not, today Indian education and healthcare is largely privatized. Highest proportion of service providers are private service providers.
So what are the nuts and bolts of that PPP system which will make it work?
So two things, right? One, government does need to spend more money on public health part of it, which is of course something the private people would not be able to spend. So taking vaccination, malaria and all of the communicable diseases,
Right.
Sanitation, water supply, health, no, all of that. So that certainly requires large public investment.
Right.
Even there we can think of PPP to some extent. But I think beyond that, when it comes to private service of healthcare, then I think we need to think about more effectively, innovatively about how to use private sector in that area. RSBY is a very good example of it.
What's that?
The Rashtriya Swadhyay Bima Yojana, the national insurance scheme, right? What it has done in a single stroke is that the fear of becoming indebted for life because of one serious disease in the family is now taken away.
Right.
Because if it requires that kind of treatment, insurance would cover that.
Right.
Expanding that coverage more,
yes,
right, and deepening that coverage, not only for 30,000 rupees, but even higher amount of that.
Right.
And slowly getting people to pay a higher proportion of the premium.
Right.
As we become little
so
better.
that is really going to be the most effective. Dhiraj.
Yes, I think it's unarguable.
And I'll do address the resource point as well. I mean, going from 2 to 4 percentage points is a fairly big jump.
Yeah, but I think, again, it's a question of what the government wants to spend on. The government spends hell of a lot, and we know that. But instead of spending so much on dole, so much on wasteful subsidies which go down the drain and really don't benefit anyone in the long run, this is one of those productive investments which will deliver returns over the long term. You know, a healthy nation is extremely important. A productive workforce is extremely important. So it's in terms of, I think we're not going to have a situation where the government can spend plus on what it's already spending. So there's going to be rationalization in some areas. Of course, we have to be very careful when we talk about doubling expenditure, because you can double expenditure and double the leakage as well.
Right.
You know, and that tends to happen.
But that's
in
a
India.
given that
but
you will.
But we can design systems where, and the incentive system I think is particularly important, and the Delta suggestion we've made go on improvements, and some state governments have shown that they are pretty good at innovating and delivering public services.
Right.
So let them be role models, and let the center transfer funds according to who's doing best.
Based on that Delta performance. I want to take a quick audience poll here, and this is: how many of you are covered by health insurance, have used it, and have been paid in time sufficiently effectively? Well, that's about 30-35%. So your point about the penetration being not very high or not being effectively used gets borne by this very urban audience that we've got sitting here, just about 30-35%.
I think I'll take this opportunity to even ask for newer products, insurance products. Right now, the insurance covers only the inpatient services.
Right.
See, the 80% of the sickness is to be dealt with or can be dealt with easily on the OPD basis,
right,
on the outpatient basis,
right,
whereas they are not covered.
Yeah. So the point coming through here is very fundamental deepening and reform of the insurance, the health insurance system. We need to take a break at this stage, but you stay right there, log into our website, thinkindia.in.com, give your suggestions, and we'll be back after a very short break. Welcome back to Change India, an agenda for the next Prime Minister. And today we are talking about how to cure India's sick health sector. We've had 2 recommendations already for the Prime Minister. One is on doubling health expenditure as a proportion of the GDP from 2 to 4 percentage points. And the other is to create an incentive system for health-linked transfers. Now we are on points 3 and 4. Point 3 is about creating a core of para-doctors who are not as specialized and as trained as specialist doctors, but really go through about a 2-year course and are able to then handle small health problems that may be happening in far-flung areas. Literally, if I was to use a colloquial phrase, bringing the quacks and training them and bringing them into the mainstream. And the second point that we have is something that's been spoken about, that in every state of India, we must have an All India Institute of Medical Sciences like super speciality teaching hospital. So that's points 3 and 4. Dr. Setya.
See, I would personally not favor a training program of just about 2 years to make paramedics or something. My point is that a fever is a fever. You don't know whether it's tuberculosis, it's malaria, unless you know about the disease or it's typhoid. So, and plus they do not know when to refer the patient when it is beyond them.
Right. So you're saying that simply the skill level required will not be there for a 2-year in a 2-year program.
Absolutely. And second, even if they do it, they eventually gravitate to the cities. You want to make them in the village setting or rural settings, they then come and practice in the cities.
Mrs. Nayyar?
Yeah, First of all, I just want to go here. I actually think you have to have a category of health workers that are based at the village level. We spoke about affordability when you're talking about insurance. The big challenge also is availability and accessibility to health services. So there has to be a trained cadre of health workers, whatever form that takes, which is based at the village level, that can do some basic treatment and then referral services, to wherever you refer it to the PHC or the district hospital, depending on what happens. I mean, we do treatment of tuberculosis through the directly observed therapy. So I think I absolutely agree there has to be a trained cadre.
And it has to be a special curriculum for them. We are also saying incentivize them with better salaries.
For the public health system, we do train auxiliary nurse midwives, and they are available. They are overburdened. Everything is put on the ASHA workers or the ANMs, as they are called.
Right.
So absolutely having like a trained nurse at a village level, and could be a person from the village who goes in for training. You create employment, you have the training person.
So let me go across to Dr. Baru. You also have that point on the AIIMS-like institution in every state, plus para-doctors.
I'm actually for the idea of a para-doctor. We already have a scheme in place which was trying to be rolled out by the present government. The resistance really came from the professionals and the IMA, etc. I also agree with Anjali Nayyar that, we can also explore the possibility of nursing practitioners. This is not something new. This has been tried in other countries. But I suspect here again the doctors will say that this is not adequate, which is not quite the case. So I think as Anjali said, I think it's very, very important to understand you can create a lot of demand, but if the supply is not matching, you're frustrating people who want to seek care but don't get care.
So clearly you're saying that this is not an ideal world, but in a semi-ideal world you'll have to look for semi-ideal solutions. Would you like to address the AIIMS point, and I'll come to Partha after that?
Yeah, the AIIMS point, my understanding of the expansion of AIIMS in every district,
every state,
AIIMS-like institutions. Yeah, every state, sorry. I think there is also a problem there of finding adequate number of doctors who would be in positions as, teachers, apart from serving in teaching hospitals. So how is that supply and going to be matched with the institutions that are going to be created? I know, for example, doctors who are leading some of these new AIIMS institutions in several states, and there is a frustration of not being able to get adequate number of people. So I mean, how do we, this will be a challenge for the next
The challenge is quality supply of teachers and doctors. Dr. Setya, since again you're the practicing doctor on the panel, very quickly your sense on, in an ideal world we would like to have AIIMS in every state. Is that doable? If doable within constraints, how would you address those constraints?
Absolutely. I think I would like the similar institutions to be set up in every state, because you have to have center of excellence.
But so how to get it done? I mean, is there a constraint, or you think the constraints would get addressed if you come in with a plan like that?
I think the constraints can be overcome.
Okay.
Clearly, because you have to budget for it. Mrs. Nayyar mentioned about the Planning Commission. The Planning Commission recommendation was that free health care to everybody. So if Planning Commission can say that, obviously they can get money for that.
Okay. So let me come to the audience here very quickly. We also have a question that and contribution that came in on the website, and that's Dr. Nitish Anchal.
I just want to ask, why not to give adequate facility and incentive to the doctors to go and serve in the rural area, rather than
what would you qualify? What would categorize as adequate?
If I have some facility to treat the patient,
right,
and the place to be livable,
right,
because many of the places are there, like where we have the public health centers, and we don't have any rooms or quarters to stay
facilities,
for
accommodation, and salaries.
Salaries, definitely.
I mean, but what levels?
More than what they are getting in the some cities.
More than that.
More than that.
So you would say more than, so it's a compensatory salary package over and above what they're getting in the
Yeah, why doctor will go to the rural area?
No, fine. So, no, I agree.
It's not uncommon actually in several international organizations saying you get a hardship allowance or something, plus on your salary if you go to a difficult posting. So I think that's not impossible to create that.
They can be incentivized in one small way also, is that, say for example, youngsters who go there, they have got life to lead. So for them, they may be given a preference for their children to be admitted in some good schools.
Right. So therefore,
and accommodation, so that it can incentivize.
So create that incentive.
Yeah.
So we know what we have to do in points 3 and 4. Let me move now to points 5 and 6. This is to do quite a bit with the bureaucracy. We are saying restructure the Union Health Ministry to create separate departments which are manned by experts, not necessarily by IAS officers, on TB, malaria and HIV. These are the 3 biggest killer diseases in India. And there is a role model that you have of the National AIDS Control Organization. So follow that pattern. That's recommendation 5. And recommendation 6 is you restructure government hospitals. You give out all the non-core services out to people who can deliver, and even some of the hospitals can be given out for private management on a non-profit basis. So these are the 2 points that we are making. Let me go across to Dr. Baru in Hyderabad, and then I'll come to the panel here.
I have great reservations on this idea of giving over government hospitals to the private sector. I think we have experiences of NGOs being, given the chance to run government institutions, and not all of them have been a great success. In fact, NGOs have sometimes given back the project to the government. I really worry about that recommendation, and I don't think it's a good idea.
So let me bring that back to the panel here, and quickly on the restructuring of the health ministry.
The only worry is why only TB, malaria and HIV? Are we going to go back to the vertical mode of functioning, which hasn't really worked? What will you say about the greatest killers of children today, diarrhea and pneumonia? Where will that find a place?
Okay, fine. Parth.
I think I agree that you need to be thinking more systematically than dividing across verticals of diseases. I think that does require very sort of serious thinking in terms of how to restructure the ministry and create its focus. I think on the other issue of giving government hospitals for private management, I think there are ways of making it work. I agree that in the past, many examples have not been very successful. And there are details of the contract and performance management and monitoring, which are a very important component of this PPP model, which have not been given enough sort of attention in the past.
Yes.
But I think given the experience we have had, we could build better systems to do that. And I think that just building capacity. I'm not saying the government should not run hospitals, but I think
but the system by which it is done, the learnings from the past, I think that's a PPP model learning that's happening everywhere, in roads, in ports, in
and just quick comment on the doctors going to rural areas. I think many countries have tried this incentive model. And frankly, none of them have worked well. So I think we should think more about the supply, and increasing supply would automatically force them to go to rural areas because they would not find enough market in the urban areas. So I think that's the better way to solve that problem.
Just a clarification on the restructuring of the health ministry. We are saying create one department focused on the biggest killers, but we're not saying this is the only thing that the health ministry should do. But let's at least get the biggest killers. I mean, these things in the rest of the world, people don't die of these things. In India, people are still dying of these things. So let's have a focused plan to get rid of mortality based on these particular diseases. And of course, the health ministry will be manned in the rest by IAS officers, by policymakers. You can't just abolish things overnight. But I think we just need some focus areas where we can make a big change very quickly.
Yeah, let me get both of you very quick interventions, Mrs. Nayyar.
Yeah, so I actually, I agree with that recommendation, because the success we've had on HIV was because we had a very separate department, the National AIDS Control Organization. And I think these departments can be within the Ministry of Health, can all the secretaries or, technical experts can report to the Secretary of Health.
Yes, structurally we can do it.
Yes, TB, if you look at TB, it's headed by a Deputy Director General, who then reports to the Director General, who reports to Joint Secretary, who reports to Additional Secretary, and then the Secretary. No decision is made, and we are looking at a drug-resistant TB emerging, and it's a serious concern.
And it need not be just these 3, we can have more.
Absolutely.
But,
pneumonia and diarrhea, I completely agree. Most 35% of the children in India die of pneumonia and diarrhea, and that has to be part of the National Health Mission or Rural Health Mission.
Let me quickly do an audience poll here. How many of you would be in favor of government hospitals being outsourced in a PPP model on a not-for-profit basis in a very transparent manner, which the bidding happens? So all the ills of the PPP model are taken out, but the good parts stay because you've had your learnings. Would you be in favor? How many of you would be in favor? Okay, so this is the new young India, which always comes in favor of let's go for more efficiency and private sector management.
I think monitoring and supervision of this would be key.
Oh no, absolutely, and this, as we've seen in all PPP models, that there are lots of learnings, but ultimately the models, once you've overcome your problems, do seem to work. We have to take a break at this stage. You stay right there. Go to our website, thinkindia.in.com, give your contributions, and come back. We'll be back very shortly. Welcome back to Change India, an agenda for the next Prime Minister. We are today talking about the initiatives that need to be taken to cure India's sick health sector. And now we are looking at points 7, 8 and 9. And these have to do with reforms and improvements and initiatives in the regulatory setup that governs public health in India. Our 7th recommendation is that the Medical Council of India should go massively on the side of e-governance, should have a 24-hour helpline. It should be receiving complaints, following up on them, everything transparently displayed. And if you've been following our shows, e-governance is emerging as a recommendation almost in every policy area. So that's 7. Then we have 8, which also has to do with to create designated consumer courts so that medical negligence cases can be very quickly settled and justice can be done. And we are saying that you need to set up tribunals manned by health experts who can deliver this justice quickly. And then the 9th one we are talking about is creation of an independent technology assessment board so that the kind of things that we hear about how indiscriminately antibiotics are being used in this country and Indians are developing sort of immunity to that. We have a technology board which can take decisions and ensure that these kind of abuses don't happen. So 7, 8 and 9. Mrs. Nayyar.
So I actually, agree with all this. I think, you have to have a 24-hour helpline. I absolutely agree with consumer courts. I would actually go a step ahead. Today what we have is, and I'm really looking at it, the Quality Council of India. These are all the regulatory frameworks and councils that exist. The Quality Council of India comes under the Ministry of Commerce and Industry. The IPHS and clinical establishment comes under Ministry of Health and Family Welfare. The medical insurance comes under Ministry of Finance. The Bureau of Indian Standards comes under Consumer Affairs. Hi. Then you've got the decisions on drug pricing policies comes under pharmaceuticals, which is under completely different ministry.
So it's a multiplicity of authorities working at cross purposes.
Then you have the CDSCO, which is your drug regulatory agency, which there have been several committee reports. And I was reading your comment about, get the new Prime Minister to dust out all the reports and use them.
Just begin implementing them.
Absolutely. The Mashelkar committee report has talked about strengthening our drug regulatory agency for years. And we need to get on with it, because what is happening now is India has a reputation of low-cost manufacturing sector. The ARVs for HIV brought the incidence down for HIV across the world, not just here. And Cipla was fabulous. So we need to strengthen
really streamline, bring all of this under a doable structure rather than have it scattered all over various arms of the government. Dr. Rama Baru, anything on points 7, 8 and 9?
I think the MCI requires a helpline, but they also need greater transparency.
Right.
And having been a member of the ethics committee, I can tell you there's a lot to be cleaned up there. The second point of the consumer court, I fully endorse. I think it's a very important step to be taken. But the technology board does not only look at drugs. I think we need to look at the issue of the deployment of high technology equipment in this country. Every other country has a norm for how many CAT scans and how many ultrasounds we should be deploying. We don't have that, and I think we need to really emulate that best practice.
So benchmark the sort of technical and diagnostic equipment. Dr. Setya.
Yeah, I think as far as points 7 and 8 are concerned, I would try and amalgamate it by asking the MCI to be given more teeth. See, today what happens is if a complaint comes and the MCI tries to settle it, all it does is that, okay, the doctor has not been wrong, or he has been wrong and can erase his name from the register permanently or temporarily. That's all it can do. But if, let's say, there is a grievance of the patient and the MCI is given an authority or is authorized to give him compensation, then a lot of burden on consumer courts would reduce. Number one.
Would you so you have that as a sort of first appeal court and then go to consumer court? Or you have, again, a multiplicity of authorities?
No, not multiplicity. In fact, I would like to reduce the burden on consumer court and let that be the first point of contact.
Right.
And in case there is a problem, then go to the district court or wherever, whatever, if you're not satisfied with that.
Right.
And I would go a step further, that MCI should have chapters in every state. There are state medical councils, and they can have chapters in districts, so that it is peripheralized and you can have the complaints redressed there itself in no time.
Partha? I think to achieve that goal, one of the biggest reform we need in MCI itself is the disciplinary committee of the MCI only has physicians as members. right? So you have a situation where doctors are deciding whether other doctors are guilty of charges or not. I think we need to change that, like the other, for example, CA.
So you would like civil society members,
yes, so
ex-bureaucrats?
Exactly. They should be the members of the disciplinary committee.
Along with doctors?
Yeah, there will be one expert doctor should be there to advise them and guide them in the medical part of it. But I think committee has to be made up of ordinary citizens.
Right.
And I think that should have given more teeth also in terms of punishing the doctors. So along with consumer court and the compensation to the patients, we need to also have a good system of discipline for the doctors who misbehave or malpractice.
Yes.
Just one more point on the pharmaceuticals part of it. I think we have great technology today in the mobile phones. Many countries in Africa actually found a way of empowering consumers through technology to check whether drugs are genuine or spurious. For example, there's a program called M-Pedigree, where every drug strip that you buy has a sort of unique ID number, the barcode that you see. You punch in that barcode in your mobile number, send the SMS out. The central server tells you back whether that medicine actually is manufactured by a company that is supposed to be manufactured or not.
Okay.
So you create a sort of system where the consumers are also in charge of making sure the medicines they consume are genuine and made by the appropriate pharmaceutical company.
Yeah, Raghav, point 789 are very critical because we are suggesting in our agenda a greater role for private sector, a greater role for para doctors. So where all that is fine and we need to address the supply problem, regulatory issues are also important because in India, for example, right now, a lot of the laboratories that conduct tests are not certified by anything. A lot of the drugs that are sold are not certified, not regulated. I mean, in fact, even by US standards, even a company like Ranbaxy was found not meeting this sort of global standards.
Right.
So I think as we expand the system, which is of course necessary, it's very important to ensure that we don't expand it without quality. So we need those boards, we need the MCI to be independent, professional, not the way it is right now, because otherwise the entire system which we are proposing will be destroyed by the very institutions is regulated.
Okay, so I'm going to come now to point number 10, and this is last but by no means the least, and you would have seen a lot of debate around this, and this is a very simple point really, and this is literally a right to life kind of point, that we have to have many more public toilets in our country, and we are suggesting that there should be at least one public toilet for 500 people in this country, and our inability to do something like this actually is a huge health hazard. I want to bring in the audience first and then I'll go to the panel on this. Thoughts on this? Yes?
Sir, even if we have public toilets, they are not maintained properly.
Right.
So we have, in Delhi, I have seen that in a few years, we have public toilets that have been built.
Right.
But they have not been maintained properly. Yes. There have been spits which are there, lying all over there.
Agreed. I think everyone has had that experience.
They should be maintained properly.
Right. Anybody else before I go to the panel?
Fine, we can have toilets throughout the country, but the issue is that we also need to understand that what are the reasons that people are not aware that how important it is that they should not go in for open defecation.
So you're saying it's not just a supply issue; it's also an awareness issue.
It's not a supply issue; it is an awareness issue
as well. Yeah. So let me go across to Dr. Baru very quickly. We have about 4 minutes left in the show. So quickly, your thoughts on how we can get this done? How can we? It sounds so simple, but how can we get it done?
No, I think this whole toilets issue has to be backed up with water supply, or you have to try alternative methods of toilet where there is a water deficiency problem. So I think the issue of supply is very, very important. If you have functional toilets, people will use it.
Mr. Nayyar?
I completely agree with Dr. Baru. And we've worked in slums of Delhi, and it's not that people don't want to use toilets, it's just that they're so dirty, and the stink and security issue for women.
So how do we address the problem? One is, as we said, of making them and then maintaining them. So how to get it done?
So there are 2 or 3 ways. One is, of course, water. Running water is absolutely essential. The second thing is there are several new kinds of toilets that have come into the market that use chemicals to just self-clean them. So there's very little maintenance that's required. And the third is educating the community, making them proud and prepared of how they need to maintain the toilets, and we've had very successful experiments.
Right.
One point I want to make is that these are all about prevention, and our focus, when you make this recommendation to the Prime Minister, the focus has to be preventive and curative, 50% across, not just curative.
I think we can rope in the corporates here as a part of their corporate social responsibility. They can make the toilets and they can maintain them, and they can use this space for advertisement.
Right. That's a good idea. And now that corporates have to spend 2% of their profits on CSR, this could be given a special sort of dispensation. Parth?
Well, I think I need to be honest, I don't use public toilets, I use private toilet. And I think our goal should be to have private toilets, not just public toilets.
Yeah, but I mean, you're a large country, and the fact that you don't have and people end up defecating in the open is actually a huge health hazard. So,
I think incentivizing them and helping them, awareness campaign, other things could be easily done.
Right.
And I think it's not that expensive to build. In the long run, you do want to have private toilets.
Yes.
Public toilets are very short term.
ASHA workers can educate them. In the rural area, ASHA workers, that is the accredited social health activists.
Right.
They are the people, they are the ladies who go to the houses. They can educate them. It is their charter.
Dhiraj, is it a resource issue? Does the central government not give enough incentive to the state governments? Because I would imagine that this is politically such a positive step for any government to do. It's almost like the food program.
Yeah, I mean, it's just that, I don't know, somehow toilets don't win votes. I mean, that's the irony of it, though they should. I think the cleanliness issue is a huge problem, but even in India, where we don't necessarily have the highest standards of hygiene anywhere, in any public space, but we have seen examples where public spaces are kept clean, for example, the Delhi metro, then people have an incentive and people have a motivation to keep it clean. So I think there's a certain awareness and there is a certain demonstration effect of actually having one or two public toilets in the village which are clean. And if people believe they are clean and can be kept clean, then they'll have an incentive to make sure that is the way all toilets are. So I think that awareness is extremely important. It's not a resource issue, and I think the next Prime Minister should certainly commit to it, because a lot of the basic illnesses which people die of in this country are because of lack of sanitation. So this is a very important preventive step which should be taken as a priority item.
And would you also have a situation where the state governments are incentivized against stiff targets, benchmarks, audits are done, so that when the resources are transferred, it's on a measurable
outcome? And I think we should audit both quantity and quality. So it's just not the number of toilets you set up. It should also involve checking how clean they are, whether their systems being clean. The state governments can outsource the cleanliness aspect to a private company, like a lot of cities are outsourcing waste management already. So there are lots of ways to do it. It's just a matter of getting it done.
Okay, I'll end with one question to the audience. Think of who will give me the interesting answer here. Why is it that the metro toilets are clean? Yes, so since you raised your hand first.
It is outsourced to Sulabh Shauchalaya. So again, a private company is maintaining it.
Okay. So anybody else wants to have any? Yes. Yes, you had a point on, in any case, on maintenance of toilets.
Yeah. So in metro, so we pay for it. And in generally you see that all these public toilets, they are not paid for.
Right.
You take 2 rupees, you take 3 rupees, but they should be maintained.
Okay. So there you are.
And that's the reason, Delhi Metro has their toilets to be clean.
Time and again, when we ask the audience for these kind of comments, it comes through that they are all for paying for services. If it's a reasonable payment, they're all for outsourcing to efficient private management. And I think while that's not a recommendation, that's something generic that the next Prime Minister should possibly heed. So there we are. All our 10 initiatives are out there for you. Before we go, here's a look at all our 10 policy initiatives to cure our sick health sector.